Ukraine visiting professors, which is named EDU Connect, with the support of the Fund of President of Ukraine for Education, Science and Sports. And first, I would like to welcome, for the welcoming word, the director of this fund, Yuri Petrushenko.
Thank you very much. Dear colleagues, students and guests, welcome and thank you for joining us today. It's a real pleasure to host this online lecture by our visiting professor from the United Kingdom, David Jayne. This lecture is a part of the visiting professor program of the Fund of the President of Ukraine for Education, Science and Sport. The program aims to bring international experts to work with Ukrainian students and researchers, share knowledge, and build strong academic connections. Opportunities like this are especially important now, as they help us stay connected to the global academic community and continue developing despite challenges. The Fund of the President of Ukraine works to support talented youth people and strengthen education, science and sport in Ukraine, and also supported internationalization of Ukrainian universities. Our goal is to invest in people, in their knowledge, skills for future, because this is what helps our country grow and move forward. We are very glad to have these opportunities to learn from our guests today, and we are also looking forward to welcoming the professor in Chernivtsi in this June to further meetings and collaboration. Thank you.
So Yuri, thank you very much for your words, and I'd like to welcome Professor Igor Gerush, Director of Bukovina State Medical University. Please.
Thank you, Ruslan. Dear members of the university community, esteemed colleagues, distinguished guests, dear students, it is a great honor and privilege for me to address you today on this important occasion for Bukovina State Medical University. We are pleased to welcome Professor Deved Jeyne from the University of Lydsa, an internationally renowned expert in a leading figure in the field of robotic surgery and advanced medical technologies. Allow me to note that I had the distinct pleasure to meeting Professor Jayne in Lydsa in 2024. That meeting lays a strong foundation for the collaboration we are launching today, and it is especially gratifying to see our dialogue evolve into meaningful academic partnership. This initiative is being implemented with the support of the Fund of the President of Ukraine for Education, Science and Sport, highlighting its strategic importance for the development of higher education and research in Ukraine. For our university, this collaboration represents a significant step forward. It opens new opportunities for the integration of advanced STEAM approaches into medical education, enhances access to cutting-edge initiatives in health tech, and contributes to strengthening our research and education capacities in a time when such advancements are particularly important for our country. I am confident that Professor Jayne's engagement with our academic community will foster productive exchange, inspire new ideas, and contribute to the development of long-term international partnerships, as well as the future joint research initiatives and grant opportunities. We are entering in a period of intensive and meaningful academic cooperation, and I am certain that the coming weeks will be both productive and inspiring for all participants. Professor David Jayne, it's my great pleasure to warmly welcome you to Bukovina State Medical University. We are truly honored to have you with us.
Thank you very much for your very kind introduction. It's a real privilege and a pleasure to present my lecture today. So I will just share my screen. So in a minute, hopefully you can see my screen now.
Yes, we see.
Excellent. So my name is David Jayne. I'm Professor of Surgery at the University of Leeds and Leeds Teaching Hospitals. Leeds is a town in the north of England, and we had the very great pleasure of having a visit from your team not so long ago. That was a very exciting event for us. So it's a pleasure to now give these lectures. You've already outlined that will be a series of 5 lectures. We've scheduled them for every Thursday morning at this time. It will be myself combined with my colleagues, Paddy Coughlin, and a few other of our colleagues who have specialist areas of expertise. And we have quite a varied agenda that we hope to share with you. So my talk today is going to be around robotic surgical systems, and we're going to look at some of their clinical applications, some of the development, the benefits and limitations of those systems, and perhaps a bit of a glimpse of what the future might hold. So I think the first thing to say is that the use of robots in surgery is not new. We've been using robots for over 4 decades. So the first robotic operation that was performed was back in 1985, so over 40 years ago now. And that was a fairly limited brain biopsy. There were developments in orthopedics, and general surgery was probably a little bit later coming onto the scene. Intuitive Surgical, as you'll be aware, are now the main manufacturer of robotic systems. They came into being in 1995. At that time, there was another system called the Zeus system, and that was made by a company called Computer Motion. And that followed a period of several years where these companies were suing each other, and generally progress was a little bit stalled. And that was resolved in 2003 when Intuitive bought out Computer Motion and then dominated the marketplace. And since then, it's really been a process of rapid development. And if we look at the Da Vinci system in particular, we first bought our Da Vinci system in 2002, and it was this first model you'll see here. It was a very big system. It took up the whole of the operating room. It wasn't that easy to use necessarily, and it only had 3 arms on it, which was somewhat restricting. You still were very reliant on an assistant. In 2003, they added a 4th arm, and that really opened up what you could do with the robot, particularly in terms of more complex pelvic dissections. Like all technology, things shrink with time, and the Da Vinci S was smaller, lighter, it was more mobile. You could maneuver it around the operating theatre or between operating theatres much more easily. The high definition vision was added, and then the dual concept. So this idea that you could have a separate console for training. In 2014, we had the Da Vinci Xi, which is the current system that we've got in our institution. And then very recently, we've had the Da Vinci DV5. So you can see the evolution of robotics over time. So the advantages of the robotic system really stem from the fact that the operator takes over total control of the procedure. Whereas in laparoscopic surgery, the operator is still very dependent on a cameraman and assistant to help him. In robotics, the surgeon actually has overall control. So he or she can control the camera, place the camera for the optimal view that he or she wants, and then it stays there, perfectly stable. So there is no wobble or anything. There's the 3D immersive experience, which really does help with surgical precision. We no longer have the laparoscopic so-called chopsticks, these instruments which can be very difficult to dissect around intricate structures. We have with the robotics, the articulated system. So again, much more precision. The surgeon sits at a console remote from the table, so it's a very comfortable operating environment. And if you're doing a low anterior resection that's going to take 4 or 5 hours, that's actually very important. And more recently, we've begun to see the introduction of haptic feedback. So into the recent DV5 system, there is some haptics. That was always a limitation with previous robotic systems, but now that's being overcome. And slowly we're seeing navigation systems being brought into these consoles as well. So this is a typical setup that we might see for a pelvic operation, an anterior resection, say. So you can see the ports are spread horizontally across the patient's abdomen. The console comes in from the side of the patient, and then the arms reach over the top. And typically we have our assistant and the scrub nurse are on the same side. So you can see here the scrub, the assistant, the robot coming in from the side. And these are the sort of procedures we tend to use the robot for. We tend to use it mainly in the pelvis for low anterior resection, where the precision and the retraction is much needed. We do a lot of pelvic prolapse surgery as well, and when you're suturing deep down in the pelvis, the ability to use the robot is just much superior to laparoscopic surgery. When we first got our robot, there was a lot of criticism around robots are very expensive. How can you justify spending all this money on a robot when the outcomes don't appear to be that different? So we set up a study. We were funded by our UK National Institute for Health Research, who funded us to run the ROLAR trial. And the ROLAR trial was looking at robotic versus laparoscopic surgery for rectal cancer. So it was a randomized controlled trial. Half the patients had robotic surgery, the other half had laparoscopic surgery. A total of 400 patients, 200 patients in each arm. They had their operation, and then we followed them up at 30 days, 6 months, and 3 years. And the primary outcome was conversion from robotic to either laparoscopic or open surgery. Excuse me. And the reason we chose that outcome was on the basis that the robot was supposed to make the operation easier. And if that was true, we should see a difference in the conversion rate. This was obviously a trial done for cancer, so we needed oncological outcomes. So we looked at the CRM, the circumferential resection margin positivity. We looked at local recurrence rates. We also looked at several functional outcomes, because rectal cancer surgery, by definition, does alter your defecatory function. We looked at quality of life, and we also looked at health economics, because of the concerns about how expensive robotic surgery was. So this had to be a truly international study because nobody at that time was doing huge volumes and there were limited number of installations of the robot. So we had UK sites, US sites, European sites, South Korea, Australia. So a truly international effort. I'm just going to briefly show you the results. So the primary endpoint, this is the conversion to open surgery. And we see in patients who had a laparoscopic operation, the conversion rate was 12.2%. It was lower with the robots, so it was 8.1%, but that didn't reach statistical significance. Interestingly, though, if we look at certain subgroups, there did appear to be a benefit for the robot. And these are typically patients who it is difficult to do laparoscopic rectal surgery on. So in our male patients, we see the conversion rate halved. It was 16% in the laparoscopic group and 8.7% in the robotic group. So a big difference. In low anterior resections, again, we saw a drop, a numerical drop in the conversion rate, and also in obese patients. But we have to be careful about drawing concrete conclusions here because these are a subgroup analysis. If we look at the reasons for conversion to open surgery, we see a similar sort of pattern emerging. And in particular, if you look at the obese patients, and this is an increasing problem in the West, we see in laparoscopic surgery, obese patients are converted in 21%, 1 in 5, whereas we didn't see any conversions in the robotic group because of obese patients. So those difficult patients, it seems that the robot might make the operation easier. In terms of the oncological outcomes, the results were good. So the overall CRM positivity was 5.7%. That sort of would be regarded as acceptable, as good actually in rectal cancer surgery. And we saw no difference between the laparoscopic or the robotic arms. And that translated into similar overall and disease-free survival. So these curves show the Kaplan-Meier curves. The robot arm is in blue. The laparoscopic arm is in red. It's 5-year data. And really, it doesn't matter whether you have a laparoscopic or a robotic operation, your cancer survival in this series, in the ROLAR series, is similar. Now, I've said the concerns about the expense of robotic surgery. This is the cost-effectiveness analysis. So you'll see at the bottom here, the total, a robotic operation is around £1,000 more expensive than a laparoscopic operation. And we looked at the costs, not just in the hospital, but also in the community. So when the patient was discharged, were they seeing their GP? Were they seeing nurses? It took into account all costs. And the difference between the robotic and the laparoscopic group was in the initial surgery. That's where the main difference was. Once the patient went home, then the costs were fairly much the same between the two groups. And if we then break down those costs that were incurred in the hospital, we see that the difference is really in the cost of the instruments. So robotic instruments are more costly than laparoscopic. Robotic operations also take longer, so the theatre costs and the costs of the theatre staff are also increased. So the main cost of robotic surgery is in the hospital, and it's driven by the higher operative costs, which in turn are due to the cost of the instruments and the fact that the operations take longer. One way of looking at cost effectiveness is to plot these acceptability curves. In the UK, we have our National Institute for Clinical Excellence, who determine what we can and can't do, or should and shouldn't do. And they will generally pay for an intervention if it falls between this cost effectiveness threshold of around 20 to 30,000 pounds. And you'll see this is the laparoscopic arm in terms of cost effectiveness. This is the robotic. Were these arms to cross in this threshold, it would mean that robotic surgery is potentially cost effective. Now, that's obviously not the case. So we are in an interesting position where we cannot demonstrate that robotic surgery is cost effective, yet it's becoming more and more widespread. So the adoption is occurring regardless of the evidence about its cost effectiveness. So there are other drivers behind this. We talked about the fact that robotic surgery takes longer. There's been a lot of interest in how long it takes to actually learn robotic surgery. The earlier publications around this suggested the learning curve might be 20 to 25 cases before you became proficient. We had a look at it within the ROLAR study. Now, the ROLAR study was surgeons who were already competent in laparoscopic surgery. So they weren't learning laparoscopic surgery. All they were doing was taking their laparoscopic skills and applying the robot to it. And we do see this is our learning curve here. If we look at the red line, we see that the red line does fall below 1. 1 means that the time taken for a robotic and laparoscopic operation are the same, they're equivalent. So it does fall below 1 at around the 30 procedures. But what you'll also see is this shaded area. This is the 95% confidence interval. So there are huge variations here. And really what you have to take into account is where this upper end of the 95% confidence interval falls below 1. And that is at 90 operations. So it is likely that the learning curve is a lot longer than was initially appreciated. The ROLAR study was performed over a decade ago now, and it is fair to say that we have to be careful when looking at those results in view of today's robotic surgery, because things have advanced. We've seen how the robotic technology has advanced. We've had improvements in our understanding of how to undertake these procedures. This is the latest study, the REAL study, the audience might be aware of. It was conducted in China, run out of Shanghai, and it was a big study. So over 1,200 patients. So 620 patients had a robotic operation and 620 patients had a laparoscopic operation. Now, the key difference to the ROLAR study is that patients had to have a mid or low rectal cancer. In ROLAR, it was all rectal cancers, including upper rectal cancer. But you might remember that I said we did see the suggestion of a benefit in ROLAR with the low cancers. And this study is purely focusing on the low cancers. And it's really exciting because, yes, it took a big number of patients to show these differences, but the differences are significant. So like ROLAR, you see a big difference in the conversion rate, which is statistically significant. but probably more important is the complete resection. So this is assessing the completeness of the completeness of the.
Excuse me, please, Alexander Moskalev, please turn off the microphone.
So this is looking at the completeness of the cancer operation. And you see with the robot, the completeness of the operation is 95.4%, which is higher than the laparoscopic group. And that translates into a significant reduction in local recurrence. So we have for the first time good robust data that actually the robot in low rectal cancer is producing a better cancer operation. So if we turn and look at how robots are being adopted, this is a little bit old now, but it shows the trends that we've seen. This is US data, and we can see that as the robot has come online, laparoscopic surgery has held fairly constant. So it may have declined a little bit, but the biggest decline has actually been in open surgery. So people are still doing laparoscopic surgery. Increasingly, they're doing robotic surgery, but what we're seeing is that open surgery is slowly being phased out. We've seen similar sort of trends in the UK, but it has been very slow. So this graph plots the use of open laparoscopic and robotic surgery over roughly 10 years. And you can see the gray shaded area here is robotic. It has been very slow. It's actually accelerated since 2022. And I suspect if we plotted this now, it would be probably around 30%, something like that. We had a spike in open surgery during the COVID years when people were nervous about aerosols, and we moved away temporarily from laparoscopic surgery. But since then, the trend has continued, and one envisages that this is going to be ongoing. In the UK, urology is still the biggest user, prostatectomy, by far and away the most common operation, followed by gynecology, and then colorectal surgery and general surgery coming after that. What we've seen, probably somewhat predictably, is that these expensive machines are being deployed in the big cities, in the big surgical centers. And that's actually introduced an inequality in itself, an access inequality. So if you live in a big city, you will get access and have surgery on a robot. If you live in a rural situation, you won't have access to it. So if there is a benefit to the robot, what we're going to see is that some people benefit whilst other people don't. And that's an area that our UK government is trying to address. The world has changed, and we have many robotic competitors coming to the market now. And it's really quite an exciting time. And one hopes that with more competitors, more choice on the market, that we'll begin to see the cost of these systems being driven down. So we have in the UK, we have a UK manufacturer called CMR, Cambridge Medical Robotics. They have their Versius system. We have the Medtronic Hugo system. We don't have many deployed in the UK of those at the moment. There are a lot of systems from China, South Korea, Japan beginning to emerge now. And there are various hybrid systems. So perhaps a robot just doing the camera and the assistant rather than a whole robotic system. So the Dexter distal motion is an example of that. The new robotic systems come with some really great technology. For me, the robotic stapling is probably one of the biggest advances. So in low rectal cancer surgery, our biggest fear is an anastomotic leak. And the ability to have an articulated stapler that you can get easily low down into the pelvis is a real advantage. And these stapling systems are so advanced now that they actually have force feedback. So they won't let you close and staple if there is too much tissue within the jaws of the stapler. So that force feedback, that safety feature, I think it's a real advance. Various vessel sealing systems are now available. They weren't available with the earlier robotic systems, and that was a real disadvantage. So having to move away from energy systems such as the harmonic scalpel to a robotic system where all you had was scissors with diathermy was a bit of a disadvantage. But now with the articulating vessel sealing system, that gives a full functionality to these robotic systems. We haven't yet got regulatory approvals for the single port, the SP system in the UK. It is being used quite a lot in South Korea. And I think we will see more and more of it being deployed, but it may be several years in the UK and Europe before we have access to it. The main use, I think, is in transanal surgery, although in South Korea it is used for a full transabdominal low anterior resection. It does, although it has the advantages of single access, there are limitations though. You will see that it articulates not at the wrist, it sort of articulates at an elbow, distal to where the scissors or the graspers are, and that is slightly different. And the instruments, they are slightly weaker, so you don't have perhaps quite the strength when you're retracting as with a multi-port robotic system. One of the biggest advantages we've found is in the ability to have dual console for teaching our residents. It is very difficult to teach someone on the robot if you only have a single console. And that's because the student is immersed in the console and is not necessarily paying attention to what the teacher is saying. And it's very difficult to communicate with someone who has their head in a box. So this ability for the trainer and the trainee to sit at different consoles and to hand over bits of the operation between the two of them is a real advantage. And I think this is a very safe way of learning robotic surgery. Of course, the robotic systems also offer up the possibility of remote proctoring. So in this example, you can see the hand of somebody in London pointing out where the operator, who's actually sat in a different country, should be operating. So they're saying, pointing out this structure here, and you need to dissect around that. And then the surgeon, who is several thousands of miles away, is able to undertake these procedures. So I think this is very, very exciting. The other area is in sort of proficiency assessment, really. It's the telemetry data that the robotic systems collects. So they can collect data on every instrument that's used, all the motions of those instruments. And so you can plot those over time during an operation. And what we see is that more novice operators tend to make a lot of movements, whereas a more experienced operator will make fewer, more precise movements. And you can use these different movement profiles to get an idea of the proficiency of the operator and indeed for credentialing. So I think we'll see more and more of this coming through. The robotic interface is a digital interface, and that lends itself to a lot of other innovation, and in particular, the incorporation of multimodal imaging. So whether that's side-by-side imaging, straightforward MRI or CT being brought in, or whether it's enhanced overlay imaging, these are all a possibility. And we're beginning to see these coming through into the more modern systems. So the DV5 has this ability to integrate DICOM images from CT and MRI. Of course, the robot is not just about the operating surgeon. It's a whole team. And putting a robot in an operating theatre does very much alter the dynamics of that team. So communication becomes very, very important. If the surgeon is sat with his head in the robot, how does he communicate effectively with the rest of the team? Because you lose that eye-to-eye contact, you lose that body language. So you need to bring in different communication skills to work effectively. And you can measure these as in this really quite nice study done. This is an example of human-machine interactions in the cardiac setting. So I think a lot more work potentially needs to be done about these new environments that we're working in. Ultimately, in the future, you may envisage that these robotic systems are going to become more and more autonomous. So the surgeon will still have control over the robotic systems, but there may be elements of an operation that the robot can do relatively unassisted. And advances in this field are happening at a frightening rate. So I was with our engineers a few weeks ago, and they showed me a robotic appendicectomy done on a pig. They used a fallopian tube to simulate an appendix, but the robotic system was able to recognize the appendix and perform an appendicectomy without any human interaction. All the human had to do was set up the robot and take the robot off at the end. So I think there are some really exciting, if not somewhat scary, developments coming down the line. This example is semi-autonomous suturing. So again, the human sets the robot up to do the suturing, but once it's placed the robotic arms, then the system can perform the suturing without any human involvement. So I hope I've been able to give you a somewhat historical overview of robotic surgery, where it started, how it's evolved, some of the evidence generation, and a glimpse of where we might be going in the future. I think this figure sums it up for me. It looks at the past, the present, and the future. And in the past, we had a surgeon and an instrument, a knife or a drill, etc. In the present, we have lots and lots of technologies. So we have different things we use in the operating theatre, different tools. We have different ways of assessing patients before they come to theatre. We have different ways, advanced ways of managing them and preventing complications afterwards. But it's all still a bit siloed. And I think in the future, there's this vision, because everything can be put on a digital platform and we have the Internet of Things, that we can actually start interlinking all this information. So when a patient comes into the system, we're no longer thinking just about the operating theatre. We're thinking about what happened before. All the information about that patient we can pull in to the operation, and likewise how those information systems flow into the perioperative and post-operative management, ultimately, hopefully, to improve surgical outcomes. So in summary, I think the surgical robotic revolution has really only just started. I think over the next 10 to 15 years, we're going to see much greater and faster innovation. Hopefully, competition in this area will drive down costs and open up access. I think the incorporation of artificial intelligence, computer vision, is going to change the way that we operate as surgeons. And possibly it's a little bit scary, the unknown of where we could be heading, but I think it's a challenge, and I think it's an area we should be proactive and we should grasp the challenge. So we shouldn't be afraid of what might be coming. We should be embracing it. We should be working with our engineers, with our computer sciences, to make sure that this technology is applied in the best and most positive way. I think we have a responsibility to do that. So thank you very much for listening. I will end my lecture now, and if there are any questions, I'd be happy to take them.
Dear Professor Jayne, thank you very much for such an interesting lecture and for your experience and for sharing it with us. And dear colleagues, if somebody have questions, please raise your hand and we'll give you a floor to ask them.
We have a question.
Yes, please.
Thank you, Dr. Jayne, for your excellent presentation. And my question will be about the usage of robotic systems in the upper GI and the HPB surgery. During our presentation, we were talking about pelvic surgery, and I would like to know, is there any data or maybe your personal experience about using those systems in upper GI and the HPB surgery? Thank you.
So I am a colorectal surgeon, so my expertise is mainly in colorectal cancer and rectal cancer. My colleagues use them in upper GI and in hepatobiliary. So in upper GI, I think it's been slower, the use and uptake. I think there was a interest in transhiatal esophagectomy, but the use of transhiatal esophagectomy, my understanding, is quite controversial. So I think, yes, there are applications in upper GI surgery, but perhaps more limited than in colorectal. In hepatobiliary surgery, yes, my colleagues are using that increasingly. In resection of liver metastases, isolated metastectomies, they're using it for biliary surgery. Increasingly, we're seeing the robot being used for simple cholecystectomy. Whether that can be justified or not, I don't know, but it's a big trend, particularly in the US. You see a lot of cholecystectomy, a lot of even hernia repairs, inguinal hernia repairs being done with the robot. But I think its real use is where you need a stable camera and you need absolute precision. So for me, something like pancreatic surgery, doing a Whipple's where you're doing the anastomosis of the pancreatic duct, that is a beautiful example where a big magnified view and the precision with very fine sutures. To me, that is something that the robots should be used for. So I think this concept almost of a hybrid operations where you might not do the whole operation with the robot, you may do a lot of it laparoscopically and then bring the robot in for a part of it. There are all sorts of different ways of deploying it. But I think over the next 10 years, this is going to become more and more the way that we do things.
Thank you.
Thank you very much. Dear colleagues, please.
Yes, Ruslan, go ahead.
And please, of course.
Okay, so hello everyone. My name is Anna. I'm the second year student at Ukrainian State Medical University, and there are two questions I would like to ask. So, first of all, you actually mentioned the incorporation of AI into robotic surgery. I do have a question regarding that because which stages of surgery can be potentially optimized, and which stages of this surgery are mandatory to be performed by humans?
I think you could optimize all of it if you wanted with the use of AI. If you look at the start of the operation, quite a lot of work has been done looking at optimum port placements. Where do you put your ports to set up the system? Because that's very, very important. If you get your ports in the wrong place, then you will struggle all the way through the operation. So using overlays to help place the ports is something that could be very useful. During the operation, I think, it's about pattern recognition. How do you recognize certain structures? And we're already seeing AI technology that will, for example, allow us to identify the ureter, that will allow us to identify the autonomic nerves down in the pelvis. This is all coming through now. So I think just every part it can be applied for. I think, there is no limit, really. The challenge is that these systems are learning systems, and so we have to be careful about becoming over-reliant on them until we're very sure that they are an accurate representation of what they're supposed to do.
Thank you so much. And the following question isn't directly related to the first one, but yet still very important. So, as I have mentioned before, I'm the medical student. And as you know, in Ukraine, we don't have currently incorporated this practice of performing surgeries. And my question is the next one. For medical students in Ukraine nowadays, which skills we need to incorporate to be prepared for the implementation of robotic surgery into our clinical practice? How we can learn it without direct practice, just to be ready for this in future?
Wow, that's a big question. So, I have to say I'm very ignorant. So, how do you do most of your surgeries at the moment? How do you do most of your operating at the moment? Is it open, laparoscopic? Do you have access to robot?
No, we don't have it.
I'm very sorry. Maybe I can particularly answer the question. Of course, and especially now, as in Ukraine, we have now great amount of surgeries that are done immediately. Mostly we operate open way, but laparoscopic surgery is widely spread, and it interfere to our everyday activity. And we may say that laparoscopic surgery is present almost in all surgical hospitals, and it's quite known technology. But for robotic surgery, there are several attempts to implement it. There are several clinics that start, but it's not widely spread technology now in Ukraine. So that's why for us it's a great interest, and that's why your lecture for us, it's also an opportunity to know more about this field.
So I think the transition from laparoscopic to robotic is quite easy. So if you are skilled in laparoscopic surgery, I think I've shown the learning curves. Yes, they are long, but we're all learning. We never stop learning, and we never stop getting better, and our times keep coming down. But if you are a good laparoscopic surgeon, all you're doing is learning to drive the robot, and it takes a little bit of getting used to, a little bit of practice. But I think you can make that switch easily enough. I think, these systems are very, very expensive. So you have to set them up as multi-specialty systems. So we have 3 robots in our hospital, but the robot that I use, we have access to it 2 days a week. The gynecologists have access to it 1 day a week. The urologists have access. So it's very much shared. And that's the only way these systems they're robots. They should be used 24 hours a day, 7 days a week. That's the only way you get value for money out of them. So if you end up having a robot that's sat there not working, that's a waste of money. So you've got to set your systems up so they are working every day. I think in terms of the question previously, I think if you buy a robot, you have to buy a dual console one. It's the only way to really learn and for residents to learn. There are consequences. We at the moment are having a bit of a problem in training some of our junior doctors, because we've seen in our region as a whole that hospitals are buying these systems and the consultants are learning on the robot, and it does have a negative impact on the juniors who aren't getting to do the cases because the consultants want to do them all. Now, this will be temporary, but you have to think of all the other unknown consequences of installing a robot.
Thank you very much.
Ruslan, we have
I'm very sorry, colleagues. I see a hand of Priyash, but we also had while registration, our colleagues also were making questions, and one of the questions is close to the previous one. Could you shortly describe the pathway of a young surgeon to become a robotic surgeon? Do they need to have experience of open surgery, and do they need to have experience in laparoscopic surgery? And approximately, if you can tell us how long does it take to become robotic surgeon?
Okay. I think ideally everyone should have exposure of open surgery. I think ideally you should get trained on laparoscopically to start with, because how we train our juniors is we will take them through an operation, but we will let them do the easier bits of the operation first. When they are comfortable with that, we'll let them do more, and it's a progressive doing more and more of the operation as we're confident that they can do so. I think, that's a little bit harder to do on the robot. I think you have to learn and be good laparoscopically first, and then afterwards you start on the robot. There can be some overlap on that, so you can be doing your laparoscopic training and then halfway through you start doing your robotic training as well. I think ultimately we'll see less and less in 10 years' time. We'll see less and less being done laparoscopically, and it may be in the future that people do start off their training robotically, and that they have very little experience of open surgery. How long does it train? Our training program in the UK is 8 years for our junior surgeons. I think you can incorporate robotic surgery within that 8 years. What most people do is do a year's fellowship at the end. So they may go to a certain center to specifically, a high volume robotic center, and they may spend 6 months, 12 months in that sort of area. And we're seeing these post-training fellowships becoming increasingly popular now.
Thank you very much. Thank you very much.
We have additional questions.
Professor Ivashuk also wants to make. Could we let Professor Ivashuk, Professor of Oncology of Bukovina State Medical University?
Yes. Do you hear me?
Yeah.
Yes. Dear Professor Jayne, I'm very glad to see you, and thank you for a very nice presentation. I have 2 questions. First questions, in your presentation, you told about when you compare laparoscopic and robotic surgery, you talked about 3-year overall survival and disease-free survival. But what about data about 5-year free survival and progression-free survival? Is the first question when I compare laparoscopic and robotic surgery. And second question, after surgery, due to NCCN guidelines, we start adjuvant systemic therapy at least 3-4 weeks after surgery. How do you think? Can we use more earlier systemic therapy after robotic surgery? Is it possible or not? Thank you.
So thank you for your questions. 2 good questions. In terms of the longer-term survival, the overall disease-free survival at 5 years, we haven't published the results from the roll-up, mainly because they didn't show any difference. They were exactly the same. So I showed you the 3-year, the 5-year. If I put the 5-year up, it's going to show the same. There is no difference. I think it will be very interesting when the real study, when that gets to 5 years, because I anticipate that will show a difference. We're already showing a difference, seeing a difference in the local recurrence. So naturally, the 5-year data, I think, will be quite quite persuasive from the real study. In terms of your second question, which I've forgotten now, I'm sorry.
About start systemic therapy, adjuvant systemic therapy
Yeah.
after surgery.
Yeah.
It takes 3-4 weeks after surgery, like a classic routine, yes, approach.
Yeah.
But after robotic surgery, can we use maybe more earlier terms?
I think that is possible. I don't have any hard data about it, but I have personal experience that patients do seem to recover quicker following robotic surgery. I think the trauma, because the robot is so precise and it's so neat and delicate, I think the trauma is less. We see patients do seem to get physically better quicker. What I don't have is hard data to support that. And if you look at our lengths of hospital stays, they're a little bit shorter in the robotic group, but they're not massively so. But I think you're right. I think patients probably do get better quicker. So you think we would be able to use adjuvant therapies quicker as well, and that's got to be a benefit.
Thank you.
Thank you very much. We have raised hand. Priyash, please.
Yes, sir. I have a question.
Please.
Yeah, thank you for such a great lecture. So I have a question regarding tactile feedback. So as we know, robotic surgeries, like most of them don't provide tactile feedback. So how big of a problem can it become, and how can we overcome it? Like as a surgeon, we rely on tactile cues of the equipment, like staplers firing or suture resistance for the tension control of the string. Does it impact the outcome? Like, for example, if we stretched string too much and causes tissue necrosis or string breaks, or the suture is just unstable, how do we compensate for it?
So yeah, thank you for that question. It's I think it's part of the learning curve with robotic surgery. When you first start doing robotic surgery, certain actions, particularly if you're suturing and tying knots, in the first few cases, you will break the suture, you will snap the suture because you have no idea how hard you're tying the knot. With a little bit of practice, you become more reliant on other cues. So, for example, visual cues. You adapt using those. So with practice, when you tie a suture, you're actually looking at how the tissue responds. And so there's a greater reliance on visual clues rather than to compensate for the tactile. And with time, that doesn't become such an issue. So there are ways you compensate.
Thank you, sir.
Thank you very much. And Anastasia, your room,
Yes.
please.
Thank you for your lecture, first of all. Across many industries right now, we are seeing a growth trend where organizations systematically collect and analyze workflow data to enable AI-driven optimization and replace the humans. In the context of surgical robotics, particularly systems which generate robust data set, including videos, instrument kinematics, and other metrics, how is the data ownership typically defined in the practice? For instance, it is primarily attributed to the surgeon, to the healthcare institution, or the technology provider. Additionally, what do you see as the main barrier in the scaling the AI integration in this domain? Are the limiting factors technical, regulatory, ethical, or legal? What is your opinion on this matter? Thank you.
Yeah, you've asked me a question where nobody knows the answer. So that's that's a huge challenge. It's not just robotic surgery. It's all digital medicine, really. There are huge challenges around ownership of the data. In the UK and Europe, and I suspect Ukraine as well, we have, the data governance laws, GDPR, which we have to conform to. So the only way around it is to properly anonymize patient data sets. If you can anonymize patient data sets, it does open up a lot of what you can do in terms of AI development. The problem though is if you need to relate those data sets back to obviously clinical data, and you've lost those unique identifiers, and that's that is problematic. So I'm not sure that there is a definite answer. At the moment, a lot of the companies, the big companies, are very keen to collect this data, particularly video data and all the meta data. They are able to do that as long as it's anonymous, in which case companies such as Medtronic, Intuitive are building big video banks for future use. I think where patient identifiers are involved, that those data sets still stay in with the hospitals and the academic institutions, and will continue to do so. So the research and development that relies on that information will stay mainly in the academic arenas. But it's a very unknown sort of area that we're really just being able to test. And I think, to briefly answer your second question, I think the development and application of AI, it's the regulations that are going to be the biggest obstacle for sure. Yeah.
Thank you.
Thank you very much. Thank you very much. Well, one more question.
Again, one more question. Yes, thank you. Professor Jayne, thank you very much for excellent lecture. I am Maxim Tashuk, a third-year PhD student in Queensland Medical University. My question is from two parts. The first one is, am I correct to assume that if it will be possible to provide every hospital in every country, or in Ukraine and in Great Britain, with a robotics system to operate on patients, it would be good to use them in every operation that would be laparoscopical without the robot. So at least partially, if not all the laparoscopic operations should be changed to robotic if we have the resources for it.
I think that's right. I think, one, if we have the resources, and also if we can drive the costs down.
Yeah.
So at the moment, I think we can only justify it when operations are complex and expensive. If you have an expensive operation, using an expensive technology is sort of absorbed a little bit into that. As inevitably the cost of these systems over time will be driven down, and therefore it becomes more sensible to use it for other things. And yes, in the future, I think most laparoscopic procedures will be done with some sort of robotic assistance. Yeah.
Yeah, thank you very much. And then the next question is, do you see, maybe now, maybe do you see that it may be visible in the future, some sort of laparoscopic operations that will be still more effective, like by hand, traditional laparoscopic surgery? Or do you think that robots will be better in all the spheres?
I think the robot is superior to the human. So ultimately, think we'll see less and less laparoscopic surgery done.
Thank you very much.
Dear Professor Jayne, thank you very much for interesting lecture and for again for sharing with us your experience and for answering for our questions. And I want to thank to the audience for activity. You see, for us, it's a great interest. And I would like to stress that it's just the first lecture in a cycle of lectures. There will be 5 lectures every Thursday this time. So you may see our announcers and join to the lectures. And we are always waiting for you and your questions. Thank you very much to everyone for joining today. Professor Jayne, thank you very much for your time and for supporting Ukraine. And yes, and see you in a week.
Thank you.
Thank you.
And please, Professor Igor Gerosh. Yeah.
Thank you, David Jayne, for your perfect lectures. Thank you for your experience and for support Ukraine. I want also say thank you to our colleague Paddy Coughlin, who also support organizing of this lecture, and for fund of our president on education, scientist and sport, for possibility to see your lecture and possibility to see you in Chernivtsi in the end of June.
Very good. Looking forward.
Looking forward.
Our great thanks to University of Leeds, that is our partner institution, and yes, to Paddy Coughlin that is doing this partnership possible for several years. Professor Jayne for supporting us, and President Fund that supports this initiative, and the program EDU Connect that brought us all here. And we hope that our cooperation will grow more and more, and you'll see many other activities that would be interesting for you. Okay, thank you very much.
Thank you. Bye.
Bye-bye.
Bye.